Right, we'll try and start. So, first of all, Thomas Souter, I'm a physiotherapist, and I'm here tonight to talk about virtual physio. Before I start, first of all, thank you for having me to present. I'm first up, so this could be an advantage or disadvantage. We shall see. So, first of all, a bit about me. I'm a physio and a sports science graduate. I've been lucky, I suppose, in my career to work across the NHS, the private sector, a bit of work in pro sport, and a bit of work in the military. So I'd like to think that I've had a bit of experience in different sectors. And I suppose that experience is echoed in the way that I think that we all sort of treat problems and address issues. This quote here, "Don't come to me with a problem, give me a solution." We hear that all the time in the military. Every day of the week, we get the officers to soldiers asking them, "I don't want problems, I want to know how you're going to treat them." And I suppose without realising, this has sort of become the backbone of not only tonight's presentation, but the concept I'm going to present, which is virtual physio. So, a bit about physiotherapy for those who don't know. Just before I continue, how many clinicians have we got in the room? We've got a few. Cool. Okay. Don't grill me too much at the end. Okay, so, bit of background. I'm not going to read through all the points on every slide, but 3 golden nuggets to take from this slide is the time, the cost, and also the impact on other services such as GPs and such as the economy. Next thing, for me to come up with a solution or to address a problem, we have to really understand and digest the concept or a current model. So we looked at the pathway, we looked at both healthcare inequalities and geographical specialisms. This could be from a patient or a practitioner point of view. We looked at secondary referrals and we looked at the management and control of MSK conditions. So how are people being managed after they see a practitioner? And once we digested and understood this, we come up with a solution, which is quite simply virtual physio. Virtual physio is a sort of a remote face-to-face physiotherapy assessment. Now, it not only allows the practitioner, the physio, to provide a treatment and an assessment of the patient, but with the inclusion of over 3,000 sort of evidence-based videos of sort of rehab, we allow the management of patients' conditions. The days of, I don't know how many people have actually seen a physio, the days of seeing a stick man are long gone. The days of poor diagrams are long gone. We can now use video. We're using this technology to improve the service. A few advantages. We've got real-time exercise demonstration. Again, for me, there's nothing worse than as a physio. You see a patient, you give them exercises, they come back 2 weeks later, they've done them incorrectly. We're allowed via this software to go through the exercises step by step. So it allows us to improve our practice. So, fair enough, great idea. But how have we turned an idea into innovative? Well, we've added value, and value for us is the key term. What we've done is by using sort of the self-referral pathway, we can reduce costs. We can reduce waiting lists. We have, by freeing up GP appointments, we're improving the service, not only in the physio sector, but allowing you to see your GP a lot quicker. Linking in with some of the orthopaedic comments just mentioned, by seeing the right practitioner first time round, we can reduce the amount of x-rays, MRI scans, orthopaedic surgery, the needs of that, which is costly. Physio is pretty cheap, £133 per session. You book in for surgery, it's pretty expensive. So we're looking at the long-term costs of healthcare. We sort of dabbled a bit here with telemedicine. So self-referral has been in the NHS for quite a few years now. Unfortunately for me as a practitioner, only 30 to 40% of GPs are picking up on this. Only 30 to 40% of GPs are using the self-referral system. So we're still quite backwards. We haven't sort of evolved really from the days of face-to-face appointments. We've got 2 great quotes here from the Department of Health and the National Medical Director showing the importance of telemedicine. The next slide shows us that the telemedicine has got potential to really change what we're doing in the NHS. And these are the things we should be harnessing. We should be really using these, and we feel that virtual physio, it's not the answer to everyone's problems, but it makes our current service just look a bit ancient. So let's use virtual physio to move us to where we need to be. For me, probably concluding with all that, great idea, you understand the problem, but what have you actually done? So, key points. Virtual physio can reduce cost, key factor for any area of the healthcare. We can reduce healthcare inequalities. It doesn't matter where you are in the country, you're going to get seen by a physio. Not a GP who's got specialists in different areas, not a physio with specialist areas, not a hospital with different specialities. We can have a localised centre what treats everybody the same, really putting patient care at equality. Reducing secondary referrals. We know from research, if a patient sees a physio first time round, we reduce secondary referrals. And that's it. Got there.
It goes super quick.
Do
hang on to that for
cool.
the questions. We've got a roving mic, so has anybody got any questions for Thomas? Great, gentleman at the back with the check shirt. It's a mic is running next to you, and then at the front. Great.
When you treat them, say, 2 or 3 sessions later, do you actually watch them do the exercise that you prescribed, or do you leave that to them to do on their own?
Well, the beauty of sort of the dual concept, we can call them back for referral, so we can do a face-to-face referral over the video consultation, or the exercise have got built-in progressions. So we know from evidence-based practice, level 1, level 2, and level 3, and it allows us to manage, not prescribe, and there's a big difference. Physio isn't a recipe. There's not one size fits all. We need to be quite adaptable, and that's what the software allows us to do.
That's all right. Thomas, thanks for your presentation. I'm Melissa, I'm an OT, work for the London Digital Programme.
Cool.
It's great to see some of the benefits around service delivery.
Yep.
What feedback have you got from actually the clients around the experience that they may have had using the product and the benefits and the health outcomes they've experienced?
I suppose the best way to answer that is we have to compare what we've got to what's currently out there. The only alternative is a telephone assessment, and the main feedback we got from that was the patient didn't feel engaged. They couldn't see the practitioner, so they don't know whether the patient's sort of filing the nails, eating the sandwich, or just sort of not fully understanding what's going on. And I think that's part of a treatment. You have that rapport with the patient as soon as they walk in, and that's the feedback we've got. They enjoy seeing face to face. And for the benefit of that, they can do it from their office. They can do it from the home. They can do it anywhere. So I suppose modifying what we've currently got and adding a few of the sort of sprinkling a bit of sugar and honey on the top to make it more of a better service.
Yeah, it's just the value of the physical manipulation versus virtual manipulation.
Yep.
You know the trigger points, the digital acupressure, and we refer patients for something acupressure.
Yeah.
You can't do acupressure on that one.
You
How do you weigh the disadvantage versus advantage on this parameter?
Now, for me, this isn't the right forum to discuss advantages, disadvantages of manual therapy. Manual therapy's got its place. Do we do manual therapy in the NHS? If we look at every service, one review, one assessment, it doesn't happen anyway. There's very limited evidence to support manual therapy. We can't keep going down this manual therapy approach. It doesn't work. I'm lucky in sport that I can do it all the time. We see patients 5 minutes, 10 minutes every day. That isn't the NHS. You've got to treat what's in front of you and the environment you're in.
Any other questions yet? Just pass it behind.
If you subtracted Skype and YouTube from the service, like what would be left?
Sorry, I don't quite follow.
This seems to be like it could also be handled just by using Skype or FaceTime and YouTube.
Yeah, it's very, very similar, but they're not HIPAA compliant. YouTube isn't guided by a professional. YouTube hasn't got that real-time engagement. So yeah, even though it's similar, let's use those benefits of those platforms and make them better. So if we subtract those subjects, we're still left with our product, but it's just a better version of what was currently out there. So that's sort of, or have I just mumbled on?
I don't quite understand what the acronym was. I'm not from the health sector. I just wasn't sure what the extra bit on top.
I suppose the only way I'll sort of go into clinical mode, if you were being assessed by someone on a YouTube or someone face-to-face over a FaceTime, what would you have more trust in? Me face-to-face or a YouTube video that could have been posted by anybody? Probably me. So that's sort of getting rid of that component, and you're doing it with a qualified provider.
Who could be using Skype?
No, they are using a Skype-style service. So you're face-to-face with Skype or FaceTime, whatever sort of terminology we put it in, you're having a face-to-face call with someone on your mobile, on a laptop, on a desktop. It removes the transport element of getting treatment.
Yep. Got it.
Sorry, just ask the gentleman here and the lady at the back. So then we'll probably be...
I guess just to put the same question differently, what's the stop the technologies like Skype and others coming in and taking this business away from you?
There isn't, and that's what's going to happen. Virtual intelligence is going to take this because we're going to use algorithms to slowly but surely, that's where the technology is going. And we can't stop that, we've just got to move the healthcare with it. Algorithms are forming so much of the NHS anyway. Most of the patients are screened by algorithms as it is. Most medical legal patients are screened using algorithms. They are there, they are being used. So we can't hide against them, they're there.
Just one very quick question, because we are at the 5 minutes.
Hi, I just wanted to ask you, so this, it's a great thing. What
Thank
is
you.
the patient group that you're catering to? Is it like the 15 to 30s, 15 to 40s? What is your highest client group?
I suppose that nicely sums up everything. In all fairness, there's no one who we don't appeal to, and surprisingly, I was talking to a chap earlier on, and the people who we thought we were going to appeal to, the older market, for use better terminology, are the people who are now using the service, who want to use it because they have so many transport issues. We thought it would be a young market coming through who are so used to using the technology, but actually the software can be used in nursing homes. It can be used for patients who who are in remote areas. So there isn't really a demographic, because for us, what we expected ended up being actually, this has got more potential than the sort of nursing home, the falls prevention, the myeloma patients. There is so many more areas where we can use this.
Wonderful, Thomas. Thank you so much. Well done.